Good evening from Kuala Lumpur, Malaysia, everyone. I'm pleased to welcome you all to this official press conference highlighting the top science from IAS 2021, the 11th IAS Conference on HIV Science. My name is Adiba Kamarul Zaman. I'm the current president of IAS, the International AIDS Society, and conference co-chair, and I'm also director of Center of Excellence for Research in AIDS at the University of Malaya here in Kuala Lumpur, Malaysia. I'm pleased to co-chair this conference with my colleague, Dr. Hendrik Streek, and we'll be doing this press briefing together. In a moment, we will hear remarks from our 5 panelists, then we will be glad to take your questions. This year, as you know, marks the 40th anniversary of the first reported cases of the disease now called AIDS, one of the worst pandemics in human history. And to date, we have lost nearly 35 million people to AIDS. IAS 2021 will be the first virtual convening of the IAS Conference on HIV Science, as another pandemic prevents many of us from convening in person. The IAS message at this critical juncture is to follow the science. 40 years of HIV research has informed the global response to COVID-19, and we now have new opportunities to adapt and enhance COVID-19 approaches and to leverage new global enthusiasm for public health, especially in the area of vaccine science. Despite the challenges of COVID-19 lockdowns, curfews, and supply disruptions, we have planned a very robust scientific program and are very pleased to share highlights of that program here today. In a moment, I will hand over to Hendrik to join me in welcoming you, and we will then introduce our 5 study authors. Each author will share opening remarks, after which we will have a joint question and answer period. If you have a question, you may submit them during speaker remarks by typing into the Q&A feature. Please either type your question in full or type the word question, and we will unmute you to pose the question directly. In both cases, please be sure to state your outlet. We'll take as many questions as we can after we hear from our speakers. The embargo is now lifted for the 5 studies featured on today's press conference. The embargo for all other studies presented at the conference lifts Saturday, 17th July 2021 at 12 noon Central European Summer Time, which is 6 a.m. Eastern Daylight Time. Now, Hendrik, over to you to introduce our speakers.
I was muted. Thank you, Adiba. Again, I'm Hendrik Streek, co-chair of the IAS 2021 in Berlin. I'm also the director of the Institute of Virology and professor of HIV research at the University of Bonn in Germany. As you all know, this conference was originally set to take place in Berlin, and my colleagues and I were excited to host the global HIV community in our capital 28 years after the World AIDS Conference was last time in Berlin. While the conference remains virtual due to the easing of COVID-19 restrictions in Germany, the IAS with the German AIDS Society, DAIC, will host a 2-day in-person meeting in Berlin. So we have a small in-person meeting, in particular featuring some plenary discussions. The IAS 2021 Berlin Hub on 19th and 20th of July will feature 5 panel discussions focusing on the HIV response. The full program will also be available to view virtually in the Berlin channel at IAS 2021.
Now I'm pleased to introduce our first speaker, who is Dr. Silvia Bertagnolio, who is a medical officer with the World Health Organization. And Silvia will present findings from a new WHO report sharing findings from the WHO Global Clinical Platform. Silvia, over to you.
Thank you very much, Adiba, for the kind introduction. Yes, today I'm presenting the briefing, the findings of the WHO report on clinical characterization and risk factors associated with in people living with HIV for COVID-19. And why WHO has released this report? Well, because understanding when the HIV infection is associated with severe and fatal COVID-19 is critical to guide public health intervention for prevention and treatment of COVID-19. And this is important globally, but particularly in low and middle income setting and in African context where the HIV epidemic is very large. So evidence regarding the risk of adverse COVID-19 outcomes in people living with HIV and the extent to which this association is modified by other factors that have been really inconsistent across different studies and geographical settings. However, latest systematic review and meta-analysis and results from large population-based studies have shown actually that there is a strong association between HIV infection and mortality in people living with HIV. So to better understand this, how HIV and COVID interplay and this link, WHO has established a global clinical platform, which include individual level patient data from all over the world globally. And this information has been used to really assess clinical characteristics and risk factors of people hospitalized with COVID-19. So at the end of April 2021, the clinical platform included 268,000 people hospitalized with confirmed or suspected COVID-19. Of those, 168,000 hospitalized individuals are coming from 37 countries. Of this number, 15,000 were people living with HIV, coming from 24 different countries. So what this large data set is telling us? Well, first of all, that people living with HIV are more likely to be admitted to the hospital with severe or critical presentation of COVID-19. And this is after adjustment by age, gender, and comorbidities. The second important finding is that people living with HIV have a higher risk of dying in hospital compared to people that are not HIV infected. This 30% increase in risk of dying is independent of age, gender, severity at admission, and comorbidity. The third important finding is that among people living with HIV, having comorbidity, being male, being over 75 years of age, is associated with increased risk of death. So these findings have important, of course, public health implications, both associated with vaccination prioritization, as well as important to assess, to stress the need for people living with HIV to stay as healthy as possible, to regularly access medication and to prevent and manage underlying conditions that can increase the risk of worse outcome. Thank you.
Thank you, Sylvia. This report certainly underscores the importance of countries, including all people living with HIV, in the list of their priority populations for vaccination, for the National Vaccine Program, yeah? And we as a global community must do more to ensure that COVID-19 vaccines go to all countries, but especially those with high HIV prevalence. So on that note, our next speaker will be Uvi Parikh, who's an associate professor of medicine in the University of Pittsburgh, Division of Infectious Diseases, and the co-director of the Global Evaluation of Microbicide Sensitivity Project. And Uvi will discuss findings on HIV drug resistance in Africa. Over to you.
Thank you for this opportunity. So daily pre-exposure prophylaxis, or PrEP, is very effective at preventing HIV. But when someone becomes HIV positive while using PrEP, there is a risk that they will get drug resistance. The goal of our study, called Global Evaluation of Microbicide Sensitivity, or GEMS, was to figure out how many people who became HIV positive on PrEP had drug-resistant HIV. This is important because the same drugs are being used for HIV treatment and prevention, and drug resistance could undermine the important progress that has been made toward ending the HIV epidemic globally. This study was done in real-world settings as part of national PrEP rollout programs in Zimbabwe, Kenya, and Eswatini, and through PrEP demonstration projects in South Africa. This was a huge coordinated effort with ministries of health and PrEP delivery partners funded by USAID and PEPFAR. We estimate that more than 104,000 PrEP users through more than 36 partners were monitored for HIV drug resistance through GEMS. We collected a blood sample from people who became HIV positive while taking PrEP and agreed to participate in the study. We tested the sample for HIV drug resistance and for evidence of tenofovir, which is one of the PrEP drugs. What we learned is from countries, we had 229 reports of HIV infection on PrEP from December 2017 to June 2021. Participants were mostly young, under age 25, and female, and the majority, or 58% of participants, were on PrEP for more than 3 months before becoming HIV positive. We had 118 drug resistance results. 1/5 of individuals, or 23%, had HIV with drug resistance that was related to the PrEP drugs, which means the mutations 184V, K65R, or K70E. Those individuals also had high levels of the HIV treatment and prevention drug tenofovir, indicating that they took PrEP at least 4 times a week. 44% of individuals had drug resistance mutations that included resistant HIV that was passed on from a partner, or NNRTI resistance. So what does all of this mean? Taking PrEP every day is very effective at preventing HIV. The number of reported infections on PrEP was very small compared to the number of PrEP users. But when taking PrEP, it's important to be regularly tested and to take it as prescribed. PrEP, like antiretroviral therapy, is effective, but resistance can be a risk with its use. However, the benefit of PrEP still outweighs this risk of resistance. And monitoring for drug resistance with PrEP rollout is important for the long-term success of both treatment and prevention programs. Thank you.
Yeah, thank you, Ruvi. Our next speaker is Francesca Colgardi, a clinical principal investigator at the WITS Health Consortium at the University of the Witwatersrand in South Africa. She will present analysis of highly resistant TB treatment in the XENIX study. Francesca, please go ahead.
Thank you very much. The XENIX trial sought to build on the success of the NEXT trial, a TB alliance study. In the NEXT trial, patients with extensively drug-resistant TB, MDR-TB treatment failure or intolerance were given a regimen of bedaquiline, pretomanid, and danezolid at a dose of 1,200 milligrams for 6 months. The success rate in the NEXT trial was 90%, an extraordinarily high rate of success in this highly drug-resistant TB population. However, it did come at a cost of adverse events. And these adverse events driven by danezolid were either peripheral neuropathy or anemia. In the XENIX trial, the one I'm presenting today, patients were randomized to one of 4 doses of danezolid, ranging from the original 1,200 milligrams for 6 months down to 600 milligrams for 2 months. The patients were given a backbone of pretomanid and bedaquiline at standard doses. I'm pleased to present the following results. 181 patients were randomized onto the trial in 4 different countries: South Africa, Russia, Georgia, and Moldova. The high rate of treatment success of around 90% was observed in all 4 doses of danezolid, from 1,200 milligrams for 6 months down to 600 milligrams for 2 months only. In terms of the adverse events of note, peripheral neuropathy was noted in 38% of patients with the highest dose and duration of danezolid, and that dropped down to 13% in the lowest dose and duration of danezolid. In terms of myelosuppression, a similar downward trend in the proportion of patients having anemia was observed. The results of the XENIX trial support the observed high efficacy of the BPAL regimen as seen in the NEXT trial. There appears to be a lower dose of adverse events of note, with a preservation of the high rate of efficacy of around 90%. Additional analyses are pending. Thank you very much.
Yeah, thank you, Francesca. Our next speaker is Consagri Nair, MTN 034 Protocol Chair at Stellenbosch University Center for Medical Ethics and Law, WHO Collaborating Center. She will present promising findings from a study of adherence to the dapivirine vaginal ring and oral PrEP among adolescent girls and young women in Africa. Lulu, please go ahead.
Thank you so much, and good afternoon from Cape Town. We undertook this study because adolescent girls and young women continue to be among those at greatest risk of acquiring HIV infection. Safe and effective methods that can and will be used by young women are critical. Daily oral PrEP has been approved in many countries, and the monthly dapivirine ring is undergoing regulatory review in several countries currently. And we're pleased to announce today that Zimbabwe has approved the dapivirine ring for use in women. But these methods and products will only work if used consistently, and young women have had challenges adhering to both PrEP, to oral PrEP and the dapivirine ring, as seen in past clinical trials. Additional safety and adherence data is required before the ring can be considered for use in adolescent girls and young women. The interim results from the REACH study show that adolescent girls and young women in Africa can and will use both oral PrEP and the dapivirine ring. We undertook this study in 3 countries in sub-Saharan Africa, namely South Africa, Uganda, and Zimbabwe. The study started in February 2019 and is expected to be concluded in October of this year. 247 adolescent girls and young women were enrolled across 4 clinical trial sites. 35% of the young women were in the 16 to 17-year-old age group. All of the participants had an opportunity to use each of these 2 products for a period of 6 months. And thereafter, in the final 6 months of the study, they get the opportunity to choose an option of these 2 study products or no option at all. Participants received tailored support and counseling. The counseling was in the form of monthly counseling sessions with trained counselors, and this counseling was based on drug level feedback. The counseling served to empower the young women to make their own decisions related to product use. What we found in the study was that adherence was higher than seen previously in other studies. And this was likely due to the amount and the type of adherence support that we offered. 97% of the participants used the ring all or some of the time, with only 3% not using the product at all. When the ring was used, 50% of the ring users were able to use it for a full month at a time. When asked to use oral PrEP, 22% of the participants were able to use it as directed. That means taking between 6 to 7 pills per week. In terms of acceptability, 88% said that they liked the ring and 64% indicated that they liked using oral PrEP. Both oral PrEP and the dapivirine ring were well tolerated and there were no safety concerns. Final results of this study are expected in the 1st or 2nd quarter in 2022, and these results will include participant preferences as well. Of course, not all young women will want to use the ring, and the same applies to oral PrEP. As life circumstances change, so will preferences. That is why having both methods and in the future additional methods is so important. But we need to give adolescent girls and young women the agency to choose the methods they believe will work for them. We think that REACH is an important study that aims to put HIV prevention in the hands of young girls and African women in Africa who need it so much. Thank you.
Well, thank you, Lulu, for presenting your abstract. Our final speaker is Rose Apondi. a behavioral scientist with the US Centers for Disease Control and Prevention in Uganda. And she's also presenting on girls and women with some troubling results, findings on increased sexual violence, HIV exposure, and teen pregnancy among girls and women in Uganda as a result of COVID-19 lockdowns and restrictions. Rose, please go ahead.
Thank you and good afternoon from Uganda. Recent data indicate that the COVID-19 pandemic is associated with increased gender-based violence penetration. In Uganda, we found that during the COVID period, there was increased sexual violence, HIV exposure, and teen pregnancy among girls and women. From routine program data, we correlated COVID-19 restrictions with gender-based violence reports among Ugandan females for HIV post-exposure prophylaxis uptake and teen pregnancy. We compared the outcomes at 2 6-month time periods, that was October 2019 to March 2020, which we call the pre-COVID-19 period, and April 2020 to September 2020, which we refer to as the COVID-19 period. Our findings, the first finding, the odds of reporting sexual violence during the COVID-19 period was 1.3 times higher compared to the pre-COVID-19 period, with a 24% increase of rape reports. The second finding, 50% of women who were raped did not come in for care within the recommended 72-hour intervention timeframe, and the main reason being lockdown restrictions. The odds of receiving post-exposure prophylaxis, an intervention important for preventing HIV acquisition, was 79% times lower during COVID-19 period compared to the pre-COVID period. In addition to what we are seeing in sexual violence, we also see an increase of 17% teen pregnancy found between the two periods. In conclusion, our study shows that during COVID-19 period, sexual violence and teen pregnancy reports increased, with likely increase to HIV exposure. It is important that investments are time-sensitive, flexible, and adaptable to gender-based violence mitigation, with special focus on young women for pandemics, especially during lockdowns. Thank you very much.
Thank you, Rose, for that presentation and the findings of some very troubling collateral damage as a result of COVID-19 lockdowns and restrictions. We will now open the floor to questions, and I'm happy to welcome Dr. Meg Doherty, Director of Global HIV, Hepatitis and STI Programs at the WHO, who will join us for this Q&A. And Meg can speak broadly about the WHO report and its implications. As a reminder, if you have a question, please submit it to the Q&A chat room there by typing into the feature at the bottom of your screen, and we will take as many questions as we can. Yeah. Leila will be monitoring the questions and reading them out. Leila?
Our first question is from Fred Libreton from Rumaid magazine in Paris. And the question is for Sylvia and Meg. Does your study specify the CD4 and viral load factors? To this day, we've had conflicting reports on whether controlled HIV is a risk factor for COVID-19 outcomes.
So thank you very much for this question, which is really critical. So the studies, the data that we presented do not have information about CD4 or viral load, as this information was not recorded. We do have information about treatment and antiretroviral therapy, but this was only available for about 60% of the individual and therefore was not included in our analysis.
Thank you. Our next question is for Francesca. Oh, sorry. Were there any differences in outcomes in the HIV patients in the study versus non-HIV, or any differences according to any other patient characteristics? Is the drug regimen compatible with antiretroviral regimen? Are there important potential interactions to be noted? To clarify, this is a final question. Based on the findings, is the 600 milligram for 6 months likely to be the best strategy? And this question is from Nancy Melville at Medscape.
Thanks, Nancy, for asking the question. And I think that these are very important questions. So in terms of HIV, in the Xenix study, only 20% of patients were HIV infected. But in the next trial, the parent study, 50% were. So we've got exposure to this regimen in about 70 patients who were HIV infected. And the outcomes were no different. Of course, in South Africa, everyone who's got TB, as everywhere, everyone who has TB is initiated onto suppressive antiretroviral therapy. So if the patient is on successful antiretroviral therapy, they are likely to succeed on the next regimen, or the Xenix regimen, or any of them. In terms of drug interactions with antiretrovirals, there's an interaction between bedaquiline and efavirenz. They cannot be co-prescribed, but we have lots of other alternatives. AZT and linezolid cannot be co-prescribed because they both cause anemia. But that means that our most commonly used antiretroviral regimen of dolutegravir, tenofovir, and lamivudine or emtricitabine can be co-prescribed. And with this, there are no potential interactions. Of course, we're still going to discuss which is the best strategy, but my personal opinion is 600 milligrams for 6 months is most likely to be the best strategy for the treatment of this highly resistant TB population group. Thank you.
As a reminder to journalists, please include your outlet when typing the question, your name and your outlet. Our next question is from Gus Carnes from AIDSmap. And he asks, will M184V make a clinical difference? This is for ORV. Will make a clinical difference if transmitted, given that it actually sensitizes HIV to tenofovir. What is your denominator, i.e. how many people were taking PrEP among whom you found that these 204 HIV infections, these 204 HIV infections? And finally, what was the 4 days a week threshold you were using in your drug level measurements? The amount quoted in your abstract seems pretty low.
Thank you for these important questions. So to address the first one, our study did not collect data on treatment success after PrEP. This is an important area for future research, but studies like ACTG 5381 are looking at the impact of resistance on dolutegravir-based therapy. I think these findings will be insightful. I think 2 key points are that seroconverters on PrEP should not delay initiation of ART, and it's important for people to who become infected on PrEP to be engaged in care. But I also want to mention that there is new data from the Nadia trial and other studies that are encouraging that dolutegravir-based therapy should be effective ART, even if you have a mutation like M184V. For the second question, this was a real world study. We did not have HIV negative people or enrolled into our study. We were monitoring people on PrEP, but we estimate that about 104,000 persons on PrEP had access to resistance monitoring. So that would be our best estimate of the denominator. So of these 104,000 PrEP users, we had 229 seroconversions reported in 2.5 years of the study. So this is less than 1% of PrEP users. And then for the third question, we did do updated analysis where we stratified the drug levels into 3 categories: low, moderate, and high. And we found that the majority of individuals with PrEP-associated mutations had tenofovir levels that corresponded to more than 700 femtomoles per punch of tenofovir diphosphate detected. So that did suggest that these were breakthrough infections. Thank you.
Next, we'll take a question from Heather Borner with Medscape. Rose, can you put your findings in context with women's viral suppression rates and generally poorer outcomes for women all over the lifespan?
Thank you very much for that question. Generally, what we were looking at was all the women who reported sexual violence. We were not looking at viral load specifically within the women who did come. However, we do HIV testing amongst the women who do come as part of the package of post-violence care. And that way, we're only looking at uptake of post-exposure prophylaxis among those who are HIV negative.
Our next question is from Sylvie Bourneuf with APM in France, and it's for WHO. Regarding the study, I did not get whether the increased risks also apply to people living with HIV who are on ARV and virologically controlled or not, and would it be possible to know the extent or the percentage of increased risks?
So thank you very much, Sylvie. Yes, so as I mentioned before, the data that we presented is not disaggregated by either viral load status or CD4 status or ART. So, what we can say that HIV infection is independently associated with poor outcome and severe or critical presentation at hospital. We are not able to assess whether this is associated with a particular condition or caused by the particular condition of the patient. However, I can say that most of the data are coming from South Africa, and where the coverage of ART is 90% or over 90%, and most of the patients are virologically suppressed, those that are on ART. So this is the population that is included in the data that we presented. So most of the population are receiving ART, and most of them are likely to be virologically suppressed. But our data does not specifically address your question.
Great. I'm trying to answer questions from journalists who haven't asked before, and I would just ask Pierre if you could add who your question is for and also your news outlet, and we'll get to that one. Javier, also, we would love your outlet. Our next question is from Rita Widodina. It's for both IAS and WHO. In Indonesia, where COVID-19 hit the country hard, people living with HIV have not yet been included in priority population for COVID-19 vaccine rollout. What do you think is the worst scenario for people living with HIV in Indonesia and other middle-income countries? Writing for the Jakarta Post.
Sylvia, do you want to take that first, and then I'll respond as well?
Sure, absolutely.
Meg?
So I think it's really important that countries really prioritize population living with HIV as a priority group for vaccination. It's really critical, and this is really a message that our report is really suggesting, and more than suggesting. It's really important that people are prioritized, and we know that globally we are so far behind that coverage that is is acceptable. So definitely is important that people living with HIV are prioritized, and WHO will include HIV infection as one of the risk group for severe and fatal COVID-19, and therefore this will be reviewed by the SAGE committee that developed the framework for assessing prioritization for vaccination. So yes, so countries really ought to take it seriously. And WHO did an informal pool of countries and whether they are prioritizing HIV, people living with HIV for vaccination. And this informal pool shows that out of 100 countries that have been requested to provide this information, 40 of them actually prioritize HIV as a critical population for vaccination. And this, of course, has to increase.
Maybe I could add one point to that. Adiba is simply put for WHO. I think our Director General and others have been mentioning in their most recent press briefings that we really need to bring vaccines around the world, that there's a critical need to have vaccine equity, and that countries in low and middle income countries where there's, say, for example, in Africa, 3 to 4% coverage only, that we need to get the first vaccine into everyone as well. The second major point here is that we also have at least 10 million people living with HIV who are unaware of their HIV status. So we need to have better, we need to ensure that people are getting tested. And in particular in South Africa, where you have many more, the majority of people living with HIV that need to be tested, need to be on antiretrovirals, need to have comorbidities monitored as well. And so irrespective of CD4 counter viral load, we would say prioritizing people living with HIV is very important. And it's already part of our policies that are up on the website that people can visit today. Thanks.
Yeah, I just want to echo that too, and just to mention that here in Malaysia, it is on the priority list. And, you know, we really hope to use this IAS 2021 to galvanize the medical community, just as the Durban conference galvanized the HIV community to ensure, you know, antiretroviral therapy reached people in low-income countries as well. You know, it took us 5 years to get there with antiretroviral therapy, and even then, you know, it took a very long time to really gain the momentum. So let's not repeat that mistake. Here it's, you know, a lot, well, it was always urgent, but here the urgency with us trying to catch up with the variants is even greater.
We have a question from Javier Sancho with El País, which is for Rose. Did you have data from HIV tested positive people among those women of the study who were victims of sexual violence? And those 50% of raped women who didn't receive care, are they caused by confinement causes? And if you just pause, I'll also add that Bern Odeni of Plus Magazine has an additional question. Did you get data on the main perpetrators of the violence, especially among teenagers?
Okay, thank you very much for those questions. And as mentioned earlier, yes, we do test as part of the program in terms of getting post-violence care. We are able to aggregate and tell the women who are actually HIV positive, and those ones are not eligible. Therefore, yes, we do have data on those ones. In terms of how many women, we had about 22,000 women in the during the COVID period that came in for post-rep care. And of those, 3,300 are the ones that managed to get post-exposure prophylaxis. However, you will find that among the 22,000, there is a percentage, about 8 to 9%, that were already positive and therefore are not included among those who do need post-exposure prophylaxis. However, the number that did need to be supported were quite a large number. In terms of the question on knowing the perpetrators, in this data, we do not include that. We do not include the analysis of who the perpetrators were. However, we know from other studies, especially the Violence Against Children survey in Uganda 2018, that most of the perpetrators are either neighbors, some of the people are really persons who live with the children in their homes, and others are from school. Those are the three big perpetrators of violence against children in Uganda. Thank you.
Next, we have two questions for Orvi. Maggie Shaw from the American Journal of Managed Care asks, were different doses of the ring and oral PrEP evaluated, and what were the determined optimal doses, if so? And Jean Barron from AVAC asks, was resistance evaluated by gender? Are there implications for lower dosing for PrEP that has been approved for MSM?
So I want to emphasize that the numbers with PrEP-related resistance was actually small. In our study, 75% of the people who became HIV positive on PrEP were women. And when I look at the data for those with PrEP-related resistance, 69% were women, so no specific trends were noted for higher resistance rates in women. That too, I can't speak to dosing recommendations for MSM based on our studies. And our study was looking only at PrEP, oral PrEP rollout. So no people in our studies had been on dapivirine ring.
Great. Our next question is from Simon Collins at HIV iBase. Please, could you say what percentage of the 118, oh, this is on drug resistance and PrEP, excuse me. Could you say what percentage of the 118 cases with results were men versus women? Important for knowing whether 4 doses were sufficient for protection or suboptimal. What percentage might be due to exposure to drug resistance in the general population? And are there any phylogenetic results from partners?
So thank you for that question. So as I mentioned, if you look at PrEP-related resistance, the proportion that had resistance that were women was similar to the proportion of women who were HIV positive in our study. Sorry, what was the second question?
I'm sorry, I've just dismissed it. Let me look. Are there any results from partners?
Oh, yes. No, we did not have any partners or any information about partners in this study.
Our next question, I believe, might be for all the panelists or for anyone who wants to answer, from PTV News in Pakistan. Can you explain anything more about how someone could be fully vaccinated for COVID, but 1 month later get results of positive results? I guess generally speaking, maybe for the panel, are you worried about new strains and what that means for HIV?
Maybe I can just chime in here, and maybe Meg wants to also complement that. So we know that vaccines are highly effective, but we also know that vaccines are 100% effective. So some people may be vulnerable to the virus even with two doses of vaccine, and this is happened for the majority of the vaccine that we have available, and they are protective, very much at the population level.
Yeah, I think that's the main message, is that the vaccination is not just to prevent infection, but to prevent severe infection or mortality. And that's what many of the efficacy studies have been looking towards. And I do think that also, if this was a two-stage vaccination, we also know that we have to give enough time for the immune response to mount enough antibodies to be able to prevent. And we also know that there are some vaccines that may or may not have the same level of protection against some of the newer variants. And certainly in the case of where the Delta variant has been, there has been some questions about whether or not all of the vaccines are going to be as efficacious against those variants. I think we'll have more studies to tell us as we go forward, but that's why the WHO has consistently said it's vaccines plus. It's not vaccines and nothing else. So vaccines plus distancing, plus masking, plus avoiding large groups, and doing all those other safety measures to prevent acquisition. So I do think that there will be more to say about this as we go forward, but certainly it's vaccines plus, and certainly right after the first one really has to make sure one is careful, because it's not an immediate free card in terms of being able to go anywhere one wants. And we've seen that now also around the world, that there are areas of the world where COVID is now increasing, and particularly in those who have not been fully vaccinated or those who have not been vaccinated at all.
Just to chime in further, I think with these breakthrough infections, generally, I think in reported cases, and certainly our observation at our own hospital, it's less than 1%. And what's most important, even in high-risk setting like with healthcare workers, those who become infected even after vaccination usually have mild disease, which is what we want, isn't it, to reduce severe disease and mortality.
We have another broad-based question from Pierre Dewale at Reflexion Medical Network in Belgium, which is what's new with long-acting or ultra long-acting treatment? Is there anything people, maybe the co-chairs, are excited about looking ahead to this conference?
What I can say is we have a plenary on antiretroviral therapy, and there are actually going to be a lot of discussions on long-acting treatment. We actually have, I think, close to a dozen sessions and 15 abstracts about long-acting treatments. Henrik, I don't know if you want to add anything specific that you've seen in the abstracts.
No, I don't think I can add anything right now at this moment.
We have a question from Sarah Jerving at DevX for Orvi. Can you compare the % of HIV positive cases in general that are drug resistant with those breakthrough cases of those using PrEP? Is it a higher percentage?
Yes, so if we look at our data in more detail, what we saw was that 55% of the individuals who were HIV positive had no drug resistance, and those who did have drug resistance were split evenly. So half of them had NNRTI mutations that were suggestive of community transmission, and half included PrEP-associated mutations. So splitting it further, of the 23% with PrEP-associated resistance, half of those had only K65R, K70E, or M184IRV, and then the other half had K65R, M184IRV with NNRTI mutations. So overall, the NNRTI or transmitted resistance seems to be greater than the PrEP-related resistance, which just reflects potential community rates and the rise of resistance in the places where PrEP is being implemented.
We have a question from Jeff Barry at Positively Aware magazine. Could you talk more about the monthly support for participants and what that entailed, and how you might see that roll out in real life settings where people likely don't have access to healthcare on a monthly basis?
So the monthly support involved counseling and counseling around use of the study product, as well as counseling around support for adherence. So the drug level feedback counseling focused on we used a semi-quantitative method of providing results in terms of no use, some use, and high use. And so we use those levels to counsel participants on the use of the study product, mainly to encourage and empower them to start using the product better. The adherence support strategies that we employed, there were several. It was a menu and it was tailored to each participant. So they got to choose what was most appropriate for themselves. And so it included like SMSs, weekly messaging, telephone calls, also sort of adherence clubs within the clinic, where they could also get support from peers. And so, so about a year of the study was actually conducted during COVID and during restrictive lockdown situations, and there we couldn't have the face-to-face interaction, so we moved to more telephonic adherence counseling, and that seemed to have worked well.
Our next question is also for whoever would like to take it. Diana Mendoza, who's a freelancer from the Philippines, is asking, what are our prospects for an HIV vaccine, given all the success we've seen with COVID vaccines?
Henrik, do you want to take this?
Sure. I mean, what the COVID-19 pandemic has shown us that if there's a strong political will behind pushing the envelope in the science, we can achieve actually much more than we currently do in HIV vaccine science. We have in now 37 years after the discovery of HIV, we had only 8 HIV vaccines in clinical testing in the phase 3. COVID-19, as you know, we had over 30 in a few months in clinical testing. That being said, it is from the structure and complexity, you can't compare SARS-CoV-2 with HIV to finding a vaccine, but it is also a truth that we could test more if there's the funding and the resources to do this. There currently is the adenovirus 26 vector vaccine from Johnson & Johnson in clinical testing right now in the phase 3. It's an Imbokodo trial in Southern Africa, as well as another version of that in the Mosaico trial in Europe and North and South America. Studies in the non-human non-human primates are encouraging, but you only know after the phase 3 trial if it's going to work. Also, the first monkey studies with an mRNA vaccine against HIV from the NIH look promising, but it is not as promising as the results that they had originally for the COVID-19 vaccine. So showing that it's just a bit more difficult. When we will have a vaccine, in particular, now comparing this to COVID-19 pandemic is very hard to say, but I agree that we could achieve much more if we keep this momentum and investment right now in ending pandemics.
We have another question from Nancy Melville at Medscape about TB for Francesca. The next TB trial shows 89% durable cure rate at 24 months. Is there a reason to believe similar duration could be seen with these lower doses? Are there any data on longer term outcomes beyond 6 months?
So in a short answer, the answer to longer term data is no, we don't have it yet. It's got to do with the passage of time. We haven't got that level of follow-up yet. What we do know from TB and in general, and in the next trial in particular, is that relapses tend to occur in the first 6 months following the end of treatment. The patients are still in follow-up, and we will be excluding any relapses, but at the moment, I don't think that there's any reason to suspect that once we've had such a good response to treatment, that we should see a higher rate of relapses post 6 months following the end of treatment.
Then we have 3 final questions, all about PrEP for Lulu. What do you think were from Heather Warner with Medscape, what do you think the keys to the trial's success were in supporting women to actually use PrEP? Are there lessons that clinicians or health systems can take from this to support young women in using PrEP? And also, what do you think were the keys to the, oh, sorry, I think that's just repeated. So there's one question from Heather, and we'll pause and then ask another.
Okay, thank you for that question. And I think it's important to note that the support was in the form of monthly support, and participants switched in terms of what they liked and how they wanted to be contacted. Dr. Connie Kellum, who's the co-chair of this protocol, recently published her findings from the HBTN 082 study, and there they had participants received adherence counseling for the first 3 months, and then thereafter it was quarterly for a year. And in her study, she saw the adherence drop sharply from over 50% to about 9% by the end of a year. So it seems like young women especially do need intensive support and counseling and to adhere to study product. And I feel that, you know, it does not have to be face-to-face. It can be done maybe remotely, telephonically, and other methods of reaching out to participants.
Great. And we have one more question, and I will just say to the media that the questions that are already in the Q&A, I think, are the final that we'll have time to respond to, and you can follow up with the media team to schedule answers for other questions. But again, Lulu, Simon Collins from HIV iBase is asking if similar resistance in men and women, it suggests that this might be infections from exposure to drug-resistant HIV. What are rough background rates of K6-5R and other mutations in the countries where the study was carried out?
I think that question could be for Irvi.
Oh, sorry.
Yes, I think that question might be for me. So the current reported rates of NRTI resistance are still low at less than 5% prevalence, but updates are expected as countries conduct more recent pre-treatment drug resistance surveys.
And another question from Javier Sancho at El País, and maybe Adiba, you'd like to start. Is there any country you would like to highlight for having promoted COVID-19 vaccine for people living with HIV as a priority population? I know, Meg and Sylvia, this is something you've looked at as well.
I must say I'm not aware of the number of countries that have included HIV specifically into the national vaccine programs, unless Meg, you are.
I could speak to that briefly, but as Sylvia had mentioned, we have done an informal survey among 100 countries, and 40 of those are prioritizing people living with HIV. It's hard to, we generally don't pick out countries, but we do have a view that we've seen this in the Americas. Many of the countries in Latin America, North America have done this, as well as certain distinct countries in Europe, as well as in Africa. I could say India and Indonesia as well have done this. So we do have a map that we'd be happy to share if as needed, but I think we congratulate all of those 40 countries who've been thinking about this and have made it a priority. And as we need to bring this also forward to other vaccine development groups in their countries for them to consider. Most of the time, we have also said under our SAGE guidelines that they need to consider their local context, and there may be other persons at greater risk, because this study, although it identifies a risk factor for HIV that's independent, there are many other risk factors as well, the comorbidities, and so that needs to also be taken into consideration on how to prioritize. But I think now that we're not in the same kind of constraint as not having enough vaccines for the world, it is about now ensuring that those vaccines we have get to where they're needed, and that the people who have the greatest risks are in the line. And that includes your first responders, your healthcare workers, people with comorbidities, and now we can add also people living with HIV. Thanks.
And our final question is from Bernard Denny of PLOS Magazine. PLOS Medicine, and it's fairly broad, maybe for the co-chairs, but what does the road to recovery of the global response to HIV look like in the face of the COVID pandemic?
Yeah, I can take that. I guess there's no doubt there's been a huge setback in HIV programs from the COVID pandemic, whether it's, you know, disruptions from lockdowns or shift of scientific research and clinical, even clinical services from HIV to COVID-19. But at the same time, I think we should look at it with optimism, really, because there were many things learned from the COVID response. You know, the use of digital technology, the innovations that many, not just in healthcare settings, but also in community groups to respond to the pandemic. I think we should learn from this and expand and you know, strengthen all the responses that have seen us through this pandemic. But equally importantly, I think, is also to use this renewed, I guess, global interest in a way in public health in general to kind of further galvanize the HIV response and use that, like Henrik said, you know, the importance of increased funding to get us to that, you know, last mile, I guess, in our quest to end AIDS. So I don't think we should be too pessimistic from the last year and a half. I think there are many lessons, many good lessons from the COVID response that can help us reinvigorate the HIV response. And to this end, actually, the Governing Council of the IAS has been having internal discussions on how we can really use the IAS platform to spur, you know, the reinvigoration of the HIV response in the next coming months. Henrik, I don't know if you want to add anything.
No, I think. I think you. I have a feedback. Maybe I'll stop talking. Now it's good. No, I think you actually said everything. What I found important as well. But I think we really need to use this momentum and use this attention right now to and to boost the scientific power behind the goal to end HIV and AIDS in particular. And I think this is actually a real frightening thought that we are in 40 years anniversary of the first discovery of the disease, and we have made, comparatively to the COVID-19 pandemic, very little progress. We have made huge progress, but we could have ended HIV and AIDS already. And I think it's time now that we really put this on the political agenda again.
So, okay, on that note, on behalf of the IAS and my co-chair, I really want to thank all of you for attending this conference. And if you have further questions, feel free to follow up with the media team and the individual speakers. Thank you also to our panelists for discussing your exciting findings in your research studies. So we'll see you at the conference next week. Bye-bye.
Bye. Thank you very much for the opportunity.
Very much.
Thank you.
Bye-bye.
Thank you all.
Thank you.